is that that initiative was really an initiative that brought together a lot of people from the Endo-ERN. Why did we consider updating the consensus on congenital hypothyroidism? And I should mention that at that stage, there is a paper that is submitted and under review, favorable review at Thyroid, and you have to realize that this paper will be 80 word pages and 233 references, and we updated the references from previous consensus, and the references from previous consensus stopped in 2013. So congenital hypothyroidism is the most frequent neonatal endocrine disorder, as you know. For example, in my Paris region, last year, congenital hypo was 1 out of 2,500 newborns. But we'll see that the numbers vary according to the region. So as you know, early diagnosis by neonatal screening program allow prevention of irreversible developmental delay. And we wish also to write and document that all the countries can use to take to the health authorities and push newborn screening for congenital hypothyroidism. There was a need for the update of the previous consensus, and because there are new data, and especially in terms of diagnosis and early treatment and the way to treat the children. In the previous consensus, central congenital hypothyroidism was very limited, and the portion dedicated to central congenital was limited. So we decided to expand it in the current consensus. And of course, in the last 7 years, there has been a lot of new genetic tools and improved and faster molecular diagnosis. And we wanted to embark those new tools into our thoughts. So this is an Endo-ERN initiative, and this is within main thematic group 8, which is dedicated to thyroid. As I said, this is endorsed by ESPE and ESC to update the previous practical guideline published in 2014, but again, the references stopped in 2013 for that previous consensus. So 22 participants from the Endo-ERN MTG8 group thyroid, including a patient representative, and I think it's very important, as you know, in the Endo-ERN, patient representative have a major role. We split the participant in 5 working groups. Working group 1 was neonatal screening, diagnosis and criteria for treatment, number 2. Number 3, treatment and monitoring. Number 4, outcome of neonatal screening and early treatment. And number 5, genetics of congenital hypo and antenatal treatment. So we searched the literature for the last 7 years, and in the manuscript, there will be actually papers who just appeared in the literature this year. We had 2 preparatory meetings at Necker University Hospital to finalize the recommendation based on published work and expert opinion. And we took time during these 2 meetings to really have a consensus on the recommendation. And then we wrote the part that was actually sustained that recommendation. And we used the same grading system as in the previous consensus, the grade grading system. So there are strong recommendation, weak recommendation, and no matter they are strong or weak, they can be based on high quality evidence, such as a placebo randomized control study. There are very few of those, of course. Moderate quality evidence, such as observational study, or randomized but not control study, for example, or low quality evidence. And the reviewers of the thyroid paper ask us also for some of the recommendation to mention that it is rather an expert consensus and an expert opinion than really a grade recommendation. So here are the names of the participants. You see people from Belgium, Netherlands, UK, Italy, France, Germany, Italy, I mentioned, and we had also some people who joined because of specific data that they had. For example, Tillmann-Rohrer from Germany has a large cohort in Germany of Down syndrome patients and has a lot of data on the thyroid function in those patients. Gabor Zinai from Basel, Switzerland, who is not part by SE on the Endo-ERN, but he has a lot of information that he wanted to share. And we invited an obstetrician, Dominique Luton from France, who participated already in the American Thyroid Association guideline for the pregnant women with thyroid disorders, because we felt that it was very important to have on the top of pediatric and adult endocrinologists an OBGYN in our group. So let's start the recommendation. And what I've done in those slides is try to present the novelty of our consensus this year as compared to the previous one. Sometimes there are novelties, sometimes there are no novelty, and we endorse what has been said previously. So this is not a surprise. We say that screening is the tool to prevent irreversible neurodevelopmental delay and optimize the developmental outcome. I think the caveat is that this should be used by physicians all over the world where there is no screening, actually newborn screening, to convince the authority to set up that screening. And if you look at the big pictures, we know that there are about 140 million births every year in the world, and there are difficult numbers to find, but through the OMS we find some numbers. Only 28% of those births are actually screened for congenital hypothyroidism, which means that 3/4 of the population, the newborns, are not screened for congenital hypothyroidism in the world. So that's really a challenge, and that should be targeted by countries who do not have that screening. Of course, it's very rewarding for the families, but also in terms of economics. And we didn't develop that, but clearly this is the most economical, valuable screening program for newborn. So let's go into some details. So the incidence is on congenital depends on the screening strategy. And for example, for primary CH, usually it's between 1 out of 3,000 to 1 in 2,000. Just to remind you, in France, we were able to have very good epidemiological study over the last 40 years. And from 82 to 2012, the incidence went from 1 out of 3,500 to 1 out of 3,000. And last year, even in Ile-de-France region, so on a quarter of the births in France, 1 to 2,500. Why is that so? The dysgenesis are not changing, the number of thyroid dysgenesis are not changing, but there are much more cases with in situ gland due to factors that we believe are environmental but needs to be found. So there is an increase over the years, and this is not only the threshold that are taken to screen, there is an authentic actually increase in the numbers of congenital hypothyroidism over the last 40 years in the countries where this is well followed and where numbers can be gathered in a sensitive and valuable way. So we still stick with the TSH as the most sensitive test for detecting primary CH, and we added to push actually to the screen for central congenital hypothyroidism that when financial resources are available, because this is very much linked to financial resources, the guidelines, the committee supports adding measurement of total or free thyroxine to screen for central CH. As you know, or as you notice in our group, Luca Persani, Paul van Trotzenburg for Holland were there, and they also wrote recently full guidelines for central congenital hypothyroidism. So this influenced our view on that. Screening labs should be aware of possible factors disturbing biochemical measurement. As we know, abnormal TH binding, autoantibodies, And we also mentioned that T4 measurement may also be useful for detecting certain form of reduced sensitivity to thyroid hormone. And I'm here alluding to the MCT8, for example, the transporters that when mutated give the very severe syndrome with mental retardation and some weird T3, T4, and TSH level, because there are new treatments that are tested at the moment, such as the TRIAC, and papers were published by the Dutch group with the help of many groups throughout Europe, showing that TRIAC may be a good way to treat this patient, at least to modify the thyrotopic axis. And there is a second trial now aiming at showing that we can improve the neuropsychological development of these young children. So if there is a treatment, then screening has its place and should be implemented. That's why we are pushing also T4 in that strategy. I know that the Dutch people are already done that for a long time, but in many countries, T4 is not actually on the filter paper determined for screening for congenital hypothyroidism. So we are pushing that. We also developed much more than in a previous consensus, the Down syndrome, because it may not be so much a problem, if I may say so, in Europe. And for example, in my country, 94% of the women who are actually having a Down syndrome child will go into therapeutic abortion. But if you look at the picture, the broader picture in the world, most of the children with Down syndrome will actually be born. And you have to realize that congenital hypo, I'm not talking about autoimmune disorders, but really some sort of dysgenesis, is 14 to 20 times higher than in non-Down syndrome children. And not only that, but data coming from Germany showed us that sometimes TSH will be normal at screening, but at the end of the neonatal period, remeasuring TSH should be considered as it can be found to be increased. Also, we mentioned that specific attention should be paid to babies born in families with primary or central CH, as recurrence may occur. And also, we went back to the clinical features, saying that clinical suspicion of hypothyroidism despite normal TSH or normal screening should prompt further evaluation for primary and central CH, and especially in children with a family history of central CH, because sometimes the physicians are reassured by the normal screening, whereas there is a delayed increase in TSH. So clinical work and clinical evaluation still has a room in that approach of the child with congenital hypothyroidism. We also insisted on the concept that abnormal neonatal screening for CH will lead to a referral to an expert center. And of course, for example, in France, we had for a long time, now more than 15 years, a rare disorder plan whereby the center are organized in reference and competence center, and there is a network throughout the country for those children to be referred. Holland has also, now the Netherlands has also such a rare disorder plan, but you know that in Europe it's not always the case. And part of the Endo-ERN aim is actually to reduce the difference in care, let's say in East Europe versus Western Europe, or in some countries versus other countries. And so I think it's important that the countries actually have criteria to define expert centers, and especially as our view is not anymore that congenital hypo is very simple, TSH is high, you put them on treatment, and that's it. No, there are syndromic forms, there are more to learn, there are fine-tuning of the treatment that need real expert center to do so. We also, as a, I would say, expert opinion, say that if TSH concentration is above 20 milliunits per liter, treatment should be started even if 3T4 is normal. This is quite an arbitrary threshold, but we felt that waiting for more time and reevaluating the child, and also starting it if after 21 days, as in the previous consensus, the TSH was still high, was maybe too late, and it was more simple to treat the child and then to sort out later on actually the etiology, the persistence of the hypothyroidism, rather than sampling blood on a regular basis for at the end treating these children. So put them in safe, treat them safely, and then sort out the situation was in a way what we felt. Of course, if serum 34 is low and TSH is low, normal, or slightly elevated, the diagnosis of central CH should be considered. Also, the people who have more experience in central CH reminded us that you should start LT4 treatment only after evidence of intact adrenal function, and if there is a coexistence between central adrenal insufficiency and the need for LT4 treatment due to central congenital hypo, then LT4 treatment must be preceded by the glucocorticoid treatment in order to prevent possible induction of adrenal crisis. So what about communicating the abnormal screening and the confirmatory results? So again, experienced professional, so member, if possible, of a pediatric endocrine team or a GP, not the best solution as a pediatrician, I think, but they should be done either by telephone or face-to-face. And in any case, in all the cases, supplemented with written information for the family. So that's the line of education. You know, it's more prominent than it used to be, and we felt that empowering the family was, as in many of our rare disorder, of extreme importance. Finally, the parents know better than some physicians who are not involved in rare disorder treatment what their children do have and what they need. So written information is a key to empowerment. That's how we felt. That's a weak recommendation, that's low evidence, but that's more kind of expert opinion. So what about imaging techniques? You know, in the past, X-ray was really pushed because if you quantify the surface of the distal femoral ossification center and the upper tibial ossification center, there was some correlation between those surface and the later development, neuropsychological and cognitive development. So we felt that we downplayed now the knee X-ray, and we pushed for using actually both ultrasonography and radioisotope scanning, if possible iodine 123, rather than technetium 99, because technetium 99 will give a higher irradiation and will not give you the information on the organification of the iodine. So we push for a dual evaluation with ultrasound and scintigraphy, and occasionally the knee X-ray to assess the severity of the intrauterine hypothyroidism. So that's a little bit different for what was said in the previous consensus. Associated malformation, very important chapter, I think. All neonates with ITSH should be examined carefully for dysmorphic features, subjective or syndromic CH. We believe that in most of the series, if you look carefully, about 10% of the children actually do have syndromic CH, and you should look for congenital malformation, of course, especially cardiac malformation. We know very well the series from Italy, but from other countries as well, where cardiac malformation are the first one to be found, about 8% in some series of the children with congenital hypothyroidism. This is also important. We know that in terms of development, the conotroncal, the anterior pole of the developing heart, has probably induction on the thyroid migration and development. And so they are close linked in terms of development between the heart, the developing heart, and the moving developing thyroid before it is in place at 7 weeks of development in the human fetus. So there was the question of the ultrasound, of the cardiac ultrasound, and I was asked this question in another setting. Certainly the one who can listen very knowledgeably to the heart. If there is a murmur, that should prompt cardiac evaluation. For me, who do not hear so well the cardiac murmur, I think I will love to have a systematic cardiac evaluation by an ultrasound in the children with congenital hypothyroidism. I would say that it depends on your settings, on your ability to get the exam, on your ability to get reimbursement for the exam, and on your ability to listen to heart murmur. But certainly 10% of syndromic CH, this is source of distress for the children, potential distress for the development of the children, and this is source of new knowledge, and we will see that in the chapter for genetics. So we should really identify those syndromic congenital hypothyroidism. Okay, treatment. Thyroxine is recommended alone as the sole and medication of choice for the treatment of CH. That was a strong recommendation and medium quality evidence. We should start as soon as possible, really no later than 2 weeks after birth. And if there was a testing and a second testing, for example, in a preterm child where it is controversial, or in a Down syndrome child, so immediately after the confirmatory serum thyroid function testing in those neonates, the treatment should be actually started. We discussed the dose, and there were good studies on that, recent one from the Berlin group and one from the New Zealand also. And when the disease is severe, defined as low free T4, let's say less than 5 picomolar per liter in the blood of the screened child, initial dose should be in the range of 10 to 15 micrograms per kilo and per day. If this is a little less severe, and certainly for in situ gland, 10 micrograms per kilo and per day should be enough as a starter. And as a general comment, we recommended brand over generic LT4 tablets. We don't like crushing tablets for newborns and putting that in water and giving that to the newborns. It's not optimal. As pediatricians, we are in a way defending bona fide medication, true medication went through the evaluation of the health authorities, and that's why we recommended brand over generic T4 tablets, particularly in severe CH and in infant. We also didn't like so much at that stage the generic preparation because of the variability that can be quite high, and that is actually tolerated by the health authorities, but that may impact negatively on the metabolic control, on the equilibrium, on the T4 level and TSH level in those children with severe CH. So let's move on now to the monitoring. So we, of course, recommend measurement of serum free T4 and TSH concentration before or at least 4 hours, this is like in the 2014 consensus, after the last daily LT4 administration. The follow-up is recommended as in the 2014 CH guidelines. And just to give you an example, the very good Berlin study from Heiko Kruder and team show that if you do the first year every month, a T4 TSH, then in almost, if I recall well, 65% of the cases, you will actually have the fine tuning of the dose that you are giving. So for the early treatment and the first year of treatment, it seems that once a month is needed to really optimize the treatment. And what is new in a way is also, we always lived with the concept of undertreatment. You shouldn't undertreat the children, TSH should be normalized. But I think what is new in a way is overtreatment conception, and you shouldn't overtreat the children as well. That's why careful monitoring is needed to really fine-tune the dose of thyroxine that you are giving to these children. You have to remember also that this fine-tuning is very important for pregnant women. if within the normal range T4 in the pregnant women is high or too low, both are impacting on the neurodevelopment of the children. This is the beautiful studies from the Generation R study from Holland, whereby women and children and offspring were followed up, and the level of T4 during pregnancy was correlated with the neurodevelopmental issue, the neurodevelopmental aspect of the offspring. So no under treatment, no over treatment, fine tuning necessitates close monitoring, probably every month the first year. So treatment and monitoring. So I'm summarizing what I just said to you. In severe form, start T4 as soon as possible after birth, at dose like in primary CH, 10 to 15 micrograms per day, per kilo and per day, in order to bring free T4 rapidly within the normal range. In milder form of central CH, we suggest starting at a lower dose. So this is again different from primary CH. In central CH, 5 to 10 micrograms per kilo and per day seems fine. In newborn with central CH, we recommend monitoring treatment by measuring free T4 and TSH according to the same schedule as for primary CH. But we know that serum free T4 should be kept above the mean median value for age-specific reference. And if TSH is low prior to treatment, subsequent TSH determination can be omitted for central CH. Of course, we pinpoint again that when under or over treatment is suspected in a patient with central CH, then TSH or free or total T3 can be measured to fine-tune the treatment. And when free T4 is around the lower limit of the reference interval, then under treatment should be considered, and particularly if TSH is above 1. So if T4 is around or above the upper limit of the reference interval, then over treatment should be considered, and particularly if it's associated with clinical sign of thyrotoxicosis and high T3. You see that T3 is mentioned when you need a fine tuning of the treatment in those children for central CH. Okay, so there are variations on the date where you can reevaluate the thyroid function. And classically, we were taught, and we taught ourselves, that after 2 to 3 years of treatment, you can stop the medication. There will be no harm to the brain development, cognitive development, and you can reevaluate the type of primary hypothyroidism. Here, we pushed a little bit differently based on several studies, including studies from Julien Léger in France. And you can see that when there is a gland in situ and there is no permanent CH diagnosis, then a dose less than 2 to 3, 2.5, 3 micrograms per kilo per day at the age of 6 months, then you can already do the reevaluation at that time. And some of these children actually, they gain weight. You don't need to increase the dose, and they are less than 3 micrograms per kilo per day at the age of 6 months. And often they will be able to be weaned off treatment, even though reevaluation, especially during puberty or if gross deceleration occurs, should be performed. So this is interesting. We don't need to, in a way, for in situ gland, we don't need to wait for 2 to 3 years before reevaluation. So here again, in primary hypothyroidism, we pushed for genetic testing because clearly that will, with thyroid imaging, give you some valuable information, and especially you will be more comfortable if you have a genetic diagnosis. In our hands, for example, in my team at the moment, and we have a submitted paper on that, for the in situ gland dysharmonogenesis, we can make the diagnosis in 50% of the cases through an NGS panel with variants that are class 4 or class 5, so pathogenic in a way, and not counting the variant of unknown significance. Whereas for thyroid dysgenesis, this is a little bit different because only 5% of the cases are so far, in only 5% of the cases we so far find a genetic background, a genetic cause for those cases. So we recommend avoiding iodine as an antiseptic drug during peri and neonatal period, as it can cause transient CH. This is not new, but let me remind you that the Voyshakov effect, which allowed the fetal thyroid to escape from iodine blockage, is only in place during the third trimester of pregnancy, during the third trimester of development, so that the premature babies are especially prone to hypothyroidism linked to iodine overload, and they won't escape through the Voyshakov effect, so it will last. So we reiterate again that's about avoiding iodine as an antiseptic drug. So we then had a chapter on monitoring of pregnant women with CH. So we changed a little bit things in comparison to the 2014 consensus, because the new consensus is rather than throughout gestation, TSH should be maintained below 2.5 milliunit per liter in patients treated with thyroxine. So following delivery, LT4 dose should be reduced to pre-conception dose, and additional thyroid function testing should be performed at approximately 6 weeks postpartum. We also insisted on the iodine intake because we believe that in Europe, and I know for sure in some region of France, that there are iodine mild deficiency, and even in some regions, severe iodine deficiency. So we reminded our readers or future readers that all pregnant women should ingest approximately 250 micrograms per day of iodine daily, and that in countries with mild to severe iodine deficiency, treatment with iodine 150 micrograms per day is recommended in all women with CH trying to become pregnant until the end of lactation. I have to remind you, of course, that they are taking thyroxine, so they have already a little bit of iodine given by the thyroxine treatment, those women who are with CH and under treatment. So here we are matching the ATA, American Thyroid Association recommendation. The chapter 4, outcome of neonatal screening, early treatment, and the impact on neurodevelopmental outcome, growth, puberty, fertility, bone, metabolic, and cardiovascular health, is quite simple nowadays. There are now a wealth of papers that have studied that in cohorts, and I know that, for example, in France, there was a national cohort, and Julian Léger has led that, and GCM papers are saying what is written here, but not only in France, in other countries. And the vast majority of early and adequately treated children with non-syndromic CH, this is very important, have a normal developmental outcome. Adequately treated children with non-syndromic CH have normal growth, puberty, fertility as studied and is very assuring, and bone, metabolic, and cardiovascular health. So we feel that if we do a good job in the neonates, find them early, treat them well, no over-treatment, no under-treatment, then we will, if I may say so, deliver to the endocrinologists for adults who are going to take care of those when they become adults. We are going to deliver healthy young people to our adult colleagues. So this is pretty reassuring and simple to summarize here. So let's move also to transition of care. You know that transition of care is a subject by itself. It's a subject in the Endo-ERN, as it was in the rare disorder plan in the country where it was implemented. And the idea is to be able to follow from, if I may say so, from the fetus state to the elderly state, the subject with endocrine condition. And clearly, here we are putting the emphasis on organizing the transition and education of parents starting at the time of the diagnosis and later on of the patient himself. Again, empowerment is essential, not only throughout childhood, but also during transition to adult care, and especially and even more importantly, in women with CH during pregnancy. So when patients are transferred from pediatric to adult care, the main aim are continuity of care. And this is not so easy because you have to remember that these children, these young adults, were never sick. They didn't see themselves never sick. So they are very confident on their doctors and they are taking their medication, and we want them and we try to persuade them to keep on taking their medication. With that, optimal clinical outcome and quality of life, there are also studies on quality of life, and to increase understanding of CH and promote self-management, so are crucial to have a successful transition of care in those children. So transition is an important chapter in the new update of the CH consensus. So for the genetic counseling, that was quite weird. In this manuscript, so 80 word pages and 233 references, we wanted to cut short the part on genetic in utero treatment, but the reviewers said that we shouldn't do that. So in the new version that we are going to resubmit very soon, we put back all the information on that. So clearly, what is crucial is that parents with a child or family with a member of CH should have access to information about the two major forms of primary CH, thyroid dysgenesis and dyshormonogenesis, and if including in the neonatal screening, about central CH. Let me remind you also how things are evolving. 30 years ago, or let's take the number for 82 in France, 1 out of 3,500 cases, 85% of dysgenesis, 15% of dyshormonogenesis. 30 years later, 1 out of 3,000, 66% of dysgenesis, 34% of dyshormonogenesis. Again, thyroid dysgenesis by itself didn't change in terms of numbers, 1 out of 5,000, but dyshormonogenesis and in situ glands with congenital hypothyroidism increased tremendously over the last 40 years. And this is not only due to the threshold for screening, this is not due because there are more premature babies, this is not due to the structure of the population with more Asian people where the congenital hypothyroidism is more frequent. This is a bona fide, a real increase in the incidence of congenital hypothyroidism due to in situ gland in general. And criteria for genetic counseling are the same as in the previous consensus. In the previous consensus, we said that if there are familial forms, if there are of thyroid dysgenesis, genetic counseling should be implemented. If there are dyshormonogenesis, of course, and this is easy, this is the recessive autosomal, so genetic counseling should be also implemented. So let's look at genetics and what we said there. So basically, there are people in those groups of the 22 authors that have labs who are performing genetic testing for congenital hypothyroidism and even unrevealing new genes in that conditions. But all we agreed that it should aim at improving diagnosis, treatment, and prognosis. So not only genetic diagnosis for the sake of research, but also for the sake of patient and family. So possibility and limits of genetic testing should be discussed with parents and family. And of course, and it's a moving field, it's a fast moving field, we should use new techniques like comparative genomic hybridization, next generation sequencing of gene panels, so targeted NGS. For example, at the Imagine Institute, which is where I have a lab in my institution at Necker, we have now a panel which went from 48 genes to 178 genes that are tested with 3 micrograms of DNA and other targeted NGS panel. And of course, whole exome sequencing is clearly or maybe clearly needed, and some are actually not going through the step of targeting NGS, but doing right from the scratch whole exome sequencing to unreveal the cause of congenital hypothyroidism. So not only thyroid dysharmonogenesis, but also familial occurrence of degenesis and central CH should lead to future genetic testing. Also, we pushed what I said about the syndromic CH. Any syndromic associations should be studied genetically, not only to improve genetic counseling this time, but also to identify new candidate gene explaining the association. This is really molecular medicine, precision medicine, personalized medicine. If you know the gene, you may know better the associated features, and you may take care in a better way of your patient. That doesn't happen so often, but we have some example and some ongoing example that this is indeed the case. So new gene implicated in primary CH recently diagnosed by NGS technique and with a well-proven biological role, that's the most difficult in the pathogenesis are reviewed in that consensus. So from my team, tubulin 1 with these big platelets, you should look at the platelet volume of your patient. If they are congenital hypothyroidism by thyroid dysgenesis and big platelets, this is a hint that tubulin 1 gene may be mutated. Again, for my group, the borealin genes, which impair the ability of the cells to migrate. From Luca Persani and other groups, the JAG1, natrin1 with cardiac malformation from the Montreal group, Johnny Deladoe, as well as other phenotype for known genes are actually reviewed, and you will read that in the consensus. And new gene responsible from central CH are also presented. So the now well-known EGSF1 with the big testis in boys, and new genes coming especially from the Dutch people who are actually screening for central CH, TBLX1X and IS4. And gene implicated in isolated or syndromic central CH are also discussed in that consensus. So what about antenatal diagnosis? Criteria for diagnosis and recommendation for management of fetal hypo, including fetal goiter, remain the same as in the previous CH consensus. In the meantime, there have been few papers on that topic, and this is always the same. If you find a goiter in the fetus, then make sure that the pregnant woman is not having hypothyroidism. If the pregnant woman has hypothyroidism, treat the pregnant woman with thyroxine, treat her from the hypo, and look at the fetal goiter. If the fetal goiter is still there, then you may have an approach, in utero approach, which is questionable by fetal blood sampling to find if the fetus has a goiter that is actually hypothyroid, and if there is compression of the trachea, or if there is amniotic fluid problems, not enough amniotic fluid or too much amniotic fluid, and there is a compression of the goiter on the trachea, then you may consider treating by intra-amniotic administration of T4 to avoid the compression of the trachea and improve the delivery of the baby. So that's about the same as in actually the previous consensus, and we put it in again upon the reviewer request in full in the new consensus. So let me finish here. That was a quite fast review. There is again 80 word pages of the manuscript, so this is a choice that I made for you here. And what you are looking at is actually the group, the 22 people who wrote the new consensus, and what you are looking at is also a Keith Haring masterpiece in Paris inside the Necker Hospital that was actually painted in '87, and we, under the wind and the snow and of that winter, we wrote the consensus on congenital hypothyroidism. So what I wanted to say to finish is that the view on the consensus is based on literature, is not based on any of the financing bodies that supported the groups that are here displayed, the people that are here shown. this is really a work on the literature and a work that we did together to really give a good documents that people throughout the world can use to convince their health authorities that congenital hypothyroidism is not a disease from the past, but is still a very interesting disease that needs its treatment, that needs its personalized medicine and its precision medicine. So I will stop here. And so we have 10 minutes or 13 minutes for question that you can send by writing to me. You can write them in the question box that you have on your screen. Thanks for being with us, and thanks for being with me for this webinar. By the way, this webinar has been recorded, and for those who had to leave or for those who are not there, that will be available on the Endo-ERN site to listen. Or for those who want to listen again to it, then you will have the Endo-ERN site where the webinar will be posted. Okay, let me try if I can see the questions. I have here a question. How do you inform the patient and the doctor on these guidelines and the impact of them? So the guidelines, they are published. So, but we know that finally maybe doctors do not read so much. So that's why we are doing these webinars. The patient associate, so there will be a dissemination through the Endo-ERN network. The webinar will be posted. There has been the announcement of this webinar, and the patient, so the patient association that are linked with the Endo-ERN will be informed also, and especially because one of the authors is actually the representative of the patient in Europe for the main thematic group 8. Then evaluation of the impact is a little bit different. What we are doing at the moment, for example, in my country, in France, is we had a national program for congenital hypothyroidism. And within that program, I gathered about 537 probants with congenital hypothyroidism. And we are indeed looking at what has been done by the physician in terms of exams. Do they have a kidney ultrasound? Do they have how was the workup of the children? And we will compare that not to the recent consensus that will be published hopefully in the next month, but to the previous consensus to see if people are actually following in any way those type of consensus. I hope I answered to your question.
In central hypothyroidism, do you consider inhibited, thus to reduce the doses, and which is your aim?
Inhibited? I'm not sure I understand, but in central, we start lower. I mean, let's talk about central hypothyroidism. There is some level of autonomous functioning of the thyroid. So people were thinking that it was not so bad, and in terms of neurodevelopment, but we know now that neurocognitive development is not optimal, and so we in this consensus we said that we should start between 5 and 10 microgram per kilo and per day for those children, for those newborns who are screened for, and it turned out that it is central hypothyroidism. And then we target the dose so that they keep a little bit above the median or the mean of the reference range for T4. So we don't look so much at TSH, except if TSH was detectable before. So T4 will be balance of transient CH is related to the current strategy of treating newborn with the TSH and normal FT4. Is it not more logical to do a second sampling after 3 weeks when FT4 is normal? Okay, so Jan, that was the attitude that was pushed in the previous consensus. But I think that there is here also a problem, is that I'm not sure that in many centers you have actually 3 T4 normative data according to postnatal age. This varies a lot. 3 T4 in a newborn, and especially in the 15th first day, are very high as compared to older children or adults. So when you say normal 3 T4, and that's why we felt that there was a danger there, we should use normative data for age-matched children, which are not readily available. So if in your center, for example, 3 T4 of 25 picomole per liter or 30, even up to 35 picomole per liter will be perfectly normal in some of the dosage for a 15 days old newborn. But 30 picomole per liter will be extremely high for an adolescent or for an adult in the same dosage. So rather than leaving it to unreliable normative data in the first month, we wanted to be on the safe side and propose to actually treat and then sort out the situation later. But in my center, in your center, probably there are very good data for age match control. I mean, we have data for the 7 first days, then 7 to 15, then 15 to 1 month. So in that settings, if 3 T4 is really normal, according to those data in the first month, then I wouldn't mind as you doing a second sampling 2 weeks later or 3 weeks later to see if TSH is increasing, T4 decreasing, and that will be a strong incentive at that time to start. But we wanted to play on the safe side. Let me answer to Kerry Kassem. Please, can you clarify the radiological investigation after confib? No. We don't. So basically, in 2020, we don't care so much about. Sorry for all those people who did those study. We don't care so much about the knee X-ray, but we pushed for both ultrasonography and isotope scan. And it will depend, of course, on the settings where you are. And if you can, in the isotope scan, have iodine 123, it's even better because radiation is very, very low, much lower than with technetium-99. And you will have the information on actually organification. Is the iodine able to fix itself on the thyroglobulin? So ultrasound, radioisotope scan, and if you have a tendency to like the old papers on knee X-ray, then do your knee X-ray, but this is not major in our view. So I want to thank you for being there. And also you can send questions, and if we didn't discuss them and questions are popping out in your mind, and they will be transferred to us, and we can then later on answer to your question. So thanks for being there, and we are going to stop now this webinar. Have a nice evening.